there in the place where you live and all around the world today. And thank you for inviting me, Eva, and Baylor colleagues, and the US Chagas community to share together with you and to speak about this amazing topic, but also a very hard topic to make research and to discuss on, because sometimes we are frustrated because not having answer to our patients. So let's start, and thanks again for everything, for letting me again be today here with you. So you are super specialist on Chagas, the most of you, but just to make a kind of framework on what is the burden of the disease today. We are speaking of a disease with a global distribution that it is not limited to traditional endemic countries from the south of the US to the north of Argentina, but also worldwide distributed in countries like Spain, in which I had the privilege to see patients for many years, for almost 20 years. Patients belonging to Latin American countries, but it's widespread in many other countries, as you perfectly know. We are speaking on a disease that potentially can affect 75 million people, and the estimated numbers of people with the infection, that, as you know, is not the same that people with the disease, it's a different concept, are 6 to 7 million based on, again, estimations. But we all know that we are underestimating the burden of this disease in terms of numbers, and also in terms of economical and social impact, that this is something super important. We know that among these 6 to 7 million people that every year that has Chagas infection, every year 1 to 2% develop organ damage. We know that it is the most common parasitic disease in the Americas and the leading cause of infection, myocarditis, worldwide, and the largest disease burden in chronic indeterminate patients. Remember that the 95% of patients or so are under this condition of chronic indeterminate. No, not 95%, 70%. This also happens to me. I became nervous in the two first slides, and then I go all the way down. So sorry for that. So we have today, and this is something we are going to speak today, indeed, two options to treat Chagas disease. And the thing is that are the two same options that we have from the mid of the last century. So we are dealing with these two drugs or medicines for 70 years at that moment. It's both are used in a 2-month regime and has a high adverse drug reaction incidence associated. And the numbers I always speak, and I tell once and once again, we have less than 10% of all these people diagnosed, underestimate and underdiagnosed, and then less than 1% of these people treated. And these are these people. These are different kind of people that have different ways of life and different life motives to migrate or to stay in endemic countries and try to search for a better life that it is difficult if we think that individually, annually we have a burden of an economic burden of the disease super high, that in terms of lifetime is around $3,400 in healthcare costs, and around $3.57. But if we translate it into what this means globally speaking, taking into account these numbers that I insist we are underestimating, we are speaking of big numbers, on really big numbers. But the worst thing is that the major part of the burden comes from loss of productivity of the people that suffer from, in this case, yes, cardiological Chagas disease, and the mortality and the morbidity induced by cardiovascular disease. So at that point, we are still trying to answer sometimes and trying to discuss sometimes this question. Is Chagas infection treatment indicated? The answer must be clear in our mind. Yes, it is indicated not because Maria Jesus Pinazo says that it is indicated, or Eva Clark says that it is indicated, or Dr. Karin Berg says that it is indicated, but because WHO technical report series says that people with chronic Chagas disease should be treated with parasiticides in areas where bacterial transmission has been interrupted. And this, it's not the second part, I mean, it's not a kind of a super clear statement. So what we can do with this bacterial transmission, so we have to prevent to have reinfections, but not to limit the diagnosis and treatment and the case management of people living in these areas in which we have still vectors turning around. From a knowledge point of view, we have been dealing for decades, you know much better than me, with all paradigms like the autoimmune origin of cardiological myocarditis, and in that case, why to treat patients. Now we know that there is evidence that say that the inflammatory immune response is triggered by the presence of the parasite. And we have also in the old school, there were not evidence that the triglycerides were in the tissues. Now we know that no matter where we search for triglyceride, we find it. So we have triglyceride finding and chronically producing this inflammatory that explain us something that were unexplained. This low inflammatory status explain us why from the acute non-treated stage, we go through a chronic one with this inflammatory background that produce the cardiological or digestive involvement. And of course, the parasite persistence is postulated as the main mechanism to of progression towards the myocardiopathy. So for all these reasons, it seems clear, and it is not something that it is said. There are studies supporting this evidence that the antiparasitic treatment is indicated. And then we have, thank you, Dr. Bern, for that. We still reference that. We try to update, but it is super difficult to do that. We have to align in several things. So, but we have, at that point, more than 10 years ago, or in 2007, if I don't remember bad, almost more than 10 years ago, we had this valuable piece that summarized all the evidence that were to recommend to recommend with strength of evidence treatment in several cases that at the end of the day are the most of the cases of people with the infection. And I am speaking of treatment with the drugs that we have, above all benzimidazole. There are more evidence with benzimidazole than with nifurtimox without not evident, with evidence against giving treatment with people that are under a severe cardiomyopathy or digestive forms of the disease, and also people that are women that are pregnant as contraindication or no indications. But in case of severe cardiological or digestive involvement, there are several clinical situations in which we can still recommend the treatment. I am thinking, for example, in these people that are undergoing an immunological, in an immunosuppressive condition. And in these cases, yes, we have to think how to deal with this immunosuppression with this chronic infection. You know by heart how is the natural history of Chagas disease. We have an acute phase after acquiring the parasite, still mainly, and we have to remind this, the main transmission way is the vectorial one. Then mother-to-child transmission, above all in non-endemic countries, and as a second transmission way, and also through transfusional and transplant and organ transplant, we can acquire the infection. And going through this acute phase, in the most of the case, we have going to assist not to assist, because we are not going to see that, because in this 90% of people we don't see signs and symptoms, and in this 10% when we see symptoms, are unspecific symptoms. So it's difficult to identify and to think on one infection that usually is transmitted by night if we are in touch with the triatomines, but they have night habits, and that it doesn't hurt, and then it's asymptomatic, the infection. So it's difficult to think in an infection that don't leave us to see that something is happening. But if we don't treat on time, and I insist, the first bottleneck is diagnosis. Remember this, less than 10%, and we don't timely treat, we go into a chronic phase. In this chronic phase, the 70% of people are going to remain in the infection site without cardiological, digestive, or cardiodigestive involvement. But here, the thing is that we don't know what are the markers. We don't know, we have not the ability to identify which are the patients that are going to develop the disease. What are going to be these 30 or 40% that are going to develop, or the cardiological, or the digestive, or the cardiodigestive form. So I told you that we have these two treatment options that you see there, bisniazole and nifurtimox, as you know. But to develop new treatment options, we need to know what are new therapeutic targets, and also how to measure the efficacy of these potential therapeutic options. Here we have not only gaps, but challenges. We have limited data on the importance of the relation of the parasite strain to human disease, and also with co-infections. And by co-infections, I mean different DTUs of the parasite. We don't know if this co-infection means, clinically speaking, something else. We don't have knowledge enough on that. And the PK/PD in Chagas is largely unknown, as well as the mechanisms of resistance. And I'm going to insist all the time on that, because I think this is as important as have new therapeutic options, is the fact that we need biomarkers of therapeutic response, because the PCR, that it has been used as a surrogate marker of cure, but it is indeed a marker of therapeutic failure, has limited sensitivity, above all in the chronic stage of the disease, in which the most of the patients are, not indeterminate 70%, but yes, the 95% of patients are in this chronic stage of the disease. So we have challenges in diagnosis and treatment. I'm going to try to center my lecture today in the treatment side, but just to remind once again that we need these early markers to assess response to treatment. But imagine that we have a marker that inform us of which are these 30% of people that are going to develop the disease. Maybe we can concentrate our effort in this 30% of people and have the security of telling the others that they are not going to have a disease progression to the disease. They are not going to have in the long of their life heart involvement or a digestive involvement. So, but we don't have this tool. So we would like, in a perfect world, to ensure the lack of organ involvement and have progression factors in our hand to assess that. And also, still we are in several areas of endemic countries. I am thinking on Mexico and in Central America. We need to accurate tests to diagnose T-cruci infection. Serological tests, as you know, are the IgG antibodies against T-cruci that are used for the diagnosis of T-cruci infection in the chronic stage of the disease. The commercial kits that we have are not useful for several populations in all the distribution of T-cruci infection. So still, we need this first step. In terms of clinical management, we need more, not only specific, but aligned clinical guidelines. If you realize, we have the PAHO guidelines that were super useful because it's kind of a general alignment, and then to desescalate this general alignment by country, adapting the clinical guidelines by country to these more general ones. And then in terms of access, we need to promote this equity through the delivery of these accurate tests of diagnosis that are useful everywhere, and increase the access to complementary tests. This is something I'm going to point it out after. In terms of research, I come back to this DDU topic because it is important. We are facing not only one parasite, we are facing several cousins of the same family, and putting together with different genetically determined hosts in all the distribution in Latin America. So if the relationship in the parasite and the host is unknown, is still, this is an extra layer of complexity to have this understanding. And I'm going to insist, we need a test for early diagnosis, the absence of organ involvement, and the progression markers. And what about treatment? And we are going to concentrate there. We know today, through last results of the clinical trials that has been published in the last 10 years, that the standard of care of treatment, the standard of care with benzimidazole, that it is 300 milligrams a day for 60 days, has an average efficacy of 80%. But we have still room to increase this efficacy and also the tolerability, because we know that because of safety issues, we have 20% of people that they don't finish their regime of treatment. So we have still this 20% gap in terms of tolerability to improve the options that we need to all of our patients that we have in these different scenarios and with different characteristics, and also 20% of possibility to increase our efficacy gap. So what we can do? So on one hand, to use the two medicines that we have today and try to see if we can use them in any other way, reducing the total dose, or by reducing the time or the daily dose. And in terms of efficacy, we are working at always when I say we, it's not only DNDi, but DNDi and collaborators and the research community. We are not the only ones that are performing studies, and we are not the only ones that are working on that, luckily. So we are working in new chemical entities, in host-directed therapies, and in the combinations of these new options, eventually also with the two old ones. So what is the strategy that DNDi and partners has been performing for 2010 to present? We have been working in new molecules as E1224 in pro-rabuconazole, in fexinidazole, and Novartis colleagues, and I cannot give details on that. It is Novartis colleagues that the ones that have the right to speak on that. But this is something that it is already public. They are starting a proof of concept with this proteasome inhibitor that is LXC408 during the next year. For sure, Natasha and colleagues, they are going to explain to you more in depth what is it about, but it is an open door at that moment in terms of new chemical entities. Also, we have in our hand again, not only DNDi. DNDi has DNDi 6148, that it's a new oxaborole, but there is a compound that AN2 has published recently. It was at the last year, I think that it was the publication of AN2 with very promising results of this another oxaborole. So we are now speaking with AN2 in order to try to compare head-to-head these two oxaboroles in order to decide what is the one that deserves to be moved into the translational phase of clinical studies. And also, There are new drugs in the discovery pipeline that we are trying to see if are the characteristics to be moved into the translational portfolio. And several groups has also worked repurposing drugs as posaconazole, the antifungal one, to try to treat Chagas disease. And of course, we are repurposing also the ones that were accepted worldwide to treat Chagas infection, as are benznidazole and nifurtimox. But for that, I insist, we need a tool to measure efficacy and to measure efficacy in a short time. You know that the gold standard accepted of response to treatment in the context of the clinical management. I'm not speaking only in the context of clinical trial. In the clinical context the one accepted is the reversion of the positive serology, that it was the diagnosis tool that we have to detect people with chronic Chagas infection. So the seroreversion that lasts 15 to 20 years to be observed is the gold standard. So we need new response to the treatment markers and also progression markers for this other area. I insist to you to give answer to our patients, to move forward research on these new therapeutic possibilities, and also to start the dialogue with regulators in order to this new therapeutic option to be accepted. For that, and this is also a limitation, and we have to think how to deal with that and how to solve that as a community. We need samples, but not only samples, no matter what samples, well-characterized samples. Regarding the new therapeutic approaches, I'm going to start with I'm going to remind something that you already know, that are the results of the studies that were published several years ago. We have the Chagas and Stop Chagas study. They both of them assess the usefulness of posaconazole. A high dose in case of Chagas, high dose was 400 milligrams twice a day for 60 days, and low dose 100 milligrams twice a day for 60 days. But as you realize, even if during treatment, during the first 60, I'm going to try to use the pointer. Here I have. If you can see to the end of the treatment, it was the efficacy was very good. Then in the follow-up, there was a lack of efficacy. It was assessed treatment failure in a high percentage in the context of Chagas study. So we know that with both high and low dose, posaconazole alone didn't show better efficacy than benznidazole. But these studies, the good thing of all of these studies is to see this. Benznidazole works. So we have adverse events, we have to manage it, but benznidazole works, and it is the medicine that we have in our hands. So to the point we don't have any other one, and if this works, we have to use it. What we observed and what was the conclusion of that, benznidazole alone was superior in terms of efficacy than posaconazole alone. And what happened if we combine posaconazole with benznidazole and compare with placebo? Something similar. Stop Chagas study didn't show better results than Chagas study. If you realize, there is with the posaconazole plus benznidazole a failure rate super high and at the end of the follow-up. So in terms of efficacy here, benznidazole, it was also superior to posaconazole plus benznidazole, and we were giving two drugs. Okay, footnote, posaconazole is super expensive, and we are treating patients. Most of the patients that we have with chronic Chagas infection are in countries in which we have to think on the economy. So if we move forward possibilities, we have also to think on that. This is something that is one of the characteristics of DNDi. So we try to work also on that. And what were the two compounds that were in our hands? We had at the time E1224, that it was a prodrug that rapidly converted to rabuconazole. It was the pro-rabuconazole with good bioavailability and long terminal half-life. And with, in terms of safety and tolerability, a very good profile. And I can tell you from a clinical point of view of patient or of physician that saw patient at the time, including in this study, super well tolerated. And also we had fexinidazole that, by the way, E1224, it was a ergosterol synthesis inhibitor. You know that the ergosterol synthesis is one of the main ways of that triglyceride has to survive. The metabolic ways, one of the main metabolic ways of triglyceride. And fexinidazole, that was the other option. It was an nitro drug, and reports in vitro and in vivo were favorable in terms of triglyceride clearance. And it was very well tolerated in humans. And as you know, it has been included, fexinidazole has been included in WHO new guidelines to treat human African trypanosomiasis. So let's go to test E1224 and fexinidazole. And what happened? I'm sorry. Here I have. I changed the slides last minute, and things happen. So in E1224 study. So in E1224 study, we had different doses and low dose, high dose, and short dose of this high dose of E1224 alone, compared with benznidazole and with a placebo of E1224, and we observed something similar, that the thing that we observed in terms of failures that we saw with posaconazole. Very good efficacy results to the end of treatment, but then we start to show treatment failure over time to the end of the follow-up in all arms of E1224, no matter what was the dose and no matter what was the length. So still, and again, benznidazole better than E1224 in monotherapy. And what happened when we same scheme? Let's combine benznidazole with E1224, and in DNDi study, and let's see what happened with benznidazole, maybe in shorter arms. So we saw that in DNDi study, benznidazole alone with shorter regimes with the standard of care daily dose was similar to the standard of care that we have. So with the caveat that this study was a super small sample size. It was a proof of concept. It was statistically strong enough, but still a proof of concept. So we need something else to confirm the hypothesis that maybe we are overdosing patients that time. Also, by the way, we have pharmacokinetic studies that told us, inform us on the same conclusion. All the studies of Dolor Soy and colleagues at Hospital Clinic of Barcelona. So again, not benefit on benznidazole combined with E1224. Still, we stay with benznidazole. So up to now, we have benznidazole alone as the best option in all the tests that we have made to this point. What happened with the other drug that we test, that was fexinidazole? We did 2 studies on fexinidazole. That was the first one in which we used this dose, 1,200 milligrams, and a higher dose, 1,800 milligrams for 8 weeks, and 4 weeks and 2 weeks, so in different lengths. And unfortunately, we had to stop. This study was set in Bolivia, as the most of the studies performed by DNDi, and I have been internal monitor or PI, so I have been in different roles. Still not in Bolivia as head of Chagas from DNDi, but hopefully soon. And unfortunately, even if the results in terms of efficacy super shorter after the treatment and to the end of the follow-up were super promising, we had to stop this study because of safety. We had severe safety issues. So, and as you say here, one of the stopping rule was safety. So we had to stop sooner than we wanted this study in Bolivia. So after going through different ethical discussions, and also coming back to review the dose and the length and how we can manage this, because it was super promising also in this very small test that we did in FEXI1. We designed FEXI12 study that was done in Barcelona. There I was the PI, still from IS Global. And we did the FEXI12 study with lower doses, with super short regimes in order to see what happened. And what happened? That was, I realized that I speak a lot. The thing that happened is that at the end of the treatment regime, results were very promising. That it is, and at the end of treatment, this rose here. You see that in the best dose option, that is the 6.0 milligrams of fexinidazole. At the end of treatment, we have only 20% of failure, but at the end of the follow-up, the primary endpoint was at 4 months. We have 73% of treatment failure. That was exactly the same percentage that we have at the end of follow-up, that was at 12 months. So unfortunately, what happened with fexinidazole is still fexinidazole is the best option that we have. So this is our option. But now the question is, are we overdosing patients? But look at what was the reaction even before having the results of FEXI12 of the community regarding the test or testing different regimes of benzimidazole and eventually nifurtimox in case of TSEO study in different studies. So different studies at that moment has recently finished or are still assessing different dose and regimes of benzimidazole and nifurtimox. And here we have done an effort performing Nuestro Bene study. Is a study that it is sponsored by ELEAN Fundación Mundo Sano, but it is being performed in collaboration with DNDi now in 6 sites in Argentina, but hopefully soon moving to Bolivia. This is a new, hopefully, not sure for, but we have Nuestro Bene study assessing these shorter range of fenflurazole. That was the hypothesis that comes from Bendita study and also from these pharmacokinetic studies I mentioned before. And there is a powerful reason here. The powerful reason, it's we are designing non-inferiority studies to assess these new regimes, but in favor of safety. That you know that way, you remind this square. I present you these schemes. I present you at the beginning. We can not only be in the efficacy limit, but increase this 20% of people that don't finish the regime of treatment because of safety. So we are moving forward this study. I want to highlight another thing, that it is when we thought in this study, we started this study, we stopped, and then we redesigned. And when we redesigned this study, we tried to make it as a study complementary to other studies that were running, and try to put the efficacy evaluation, the primary endpoint, but also the efficacy endpoints in the same place than other studies, because I think that the strength that we are going to have finishing and analyzing all this study is then meta-analyzing what has happened in terms of efficacy and safety. So from there, we can extract strong evidence to give response to our patients. So, and this is a summary. What we are doing now at DNDi, there is a super active pipeline in discovery. My colleagues of Hit to Live are working. I see Dr. Wagner in the screen with University of Washington series, together with collaborators always. And there is a strong commitment of on try to search in molecules libraries different strategies and different possibilities to be moved into translation. And in translation at that moment, I remind you that we're working, as you can imagine, because my insistence in biomarkers, and we have this 6148 try to compare head to head with this another oxaborole that Anacor has, if we agree to do this together with them. Unfortunately, and due to the bad results of fexinidazole, it is in standby, but we have the possibility through a collaboration with those 4 colleagues and IDDO colleagues to understand better what has happened with this change of dose in terms of efficacy of fexinidazole. And Novartis is moving forward, and we belong to the clinical trial team of this proof of concepts of LXC. In terms of clinical development, we have now these new regimes of benzimidazole, this Nuestro Ben study assessing 15 and 30 days of benzimidazole at 300 milligrams a day. And in terms of implementation, we are trying to increase, and here heads up, we are not using the pediatric formulation of benzimidazole. We have to raise awareness on that, because if we don't use that, maybe the industry are not going to produce it again. It was a hard way, and super long and hard way to produce and to approve that for the use. So it is important to raise awareness and that we have a pediatric benzimidazole, and not to split pills and make the solution in order to give to young people, to children. For that, I cannot stay here and not speak of biomarkers. We need biomarkers, but here the first step is we need a consensus. What are we searching for? It is clear that we want to kill the parasite, but what happens if we don't kill the parasite? It is enough if we decrease the parasite load in order to not to move the infection to Chagas disease at some point, or we need something to identify what is this no progression we're speaking about in clinically speaking. So in terms of biomarkers, there is a universe of different biomarkers assessing cardiological damage, the digestive damage, and several of them are also being used as therapeutic response one, even if it is not the same scenario. So at that point, we have several biochemical biomarkers that were tested at the time. None of them satisfactory in terms of what we expect from them. Immunological ones that are very well positioned, the ones that are being developed from the group of Dr. Igor Almeida at UTEP, at El Paso, and University of Texas, and the ones that rely in TQSI antigens, the ones in KMPA11, HSP17, and all the series that also has been used for the cardiological and digestive characterization of patients. The Infinity multiplex are super well positioned. There is a publication that is coming, that it is already accepted. Be ready for read it, and I think this is very well positioned. We are working together with Infinity. My colleagues of Discovery are working on that, and also other markers based on antigens belonging to the protein. At the time, to assess the performance of all these markers, we built a TPP, a target product profile. There was one 10 years ago developed by Nepacha Network. And there was 4 years ago an update also from Nepacha Network that dig in deep of the characteristics that we were asking to a biomarkers in terms of sensitivity, specificity, expression of the marker in different population. I insist, we are speaking of people belonging to a full continent. So the expression of several of these markers is not evident. We have to assess that they are expressed and then they decrease or increase, they change over time after a treatment regime. So we make this evaluation taking into account these characteristics. By the way, this AB3 is one of the main proteins of multicruci. So still, PCR is the best tool that we have to assess response to treatment, above all in the context of clinical trial, but with all the limitations that you know in the context of clinical use. In the context of clinical trial, we make 6 PCRs in each time point. In the clinical scenario, no. In the clinical scenario, if we reach to have one, we are lucky. If we think in the countryside of Cochabamba, maybe it's a bit more difficult to implement that in the context of a clinical trial, right? We have also, because we are speaking on the parasite side, we have also to identify what are the markers that eventually we can use to assess this organ damage. For the moment, we assess cardiological involvement and digestive involvement through anamnesis, physical examination, and some tests like the echocardiography. With the spectral tracking, we know that we can identify pretty well which are the patients that have a cardiological involvement in a preliminary stage, but not all the people in the places in which the most of the people with T-cruci infection are known to do this spectral tracking. And on the other hand, we have molecular markers like BMP, with whom we can identify in people with normal ECG 25% with abnormal diastolic function. So let's be ready to implement this kind of markers in the identification of people with early cardiological involvement. And something that is kind of coming from the NASA, if we speak in a country like Bolivia, cardiac MRI, perfect. We have this delayed enhancement in several areas of the heart, but we have here a problem of access, and we have to be conscious of that. Something similar happens with the digestive involvement, in which we have the clinical evaluation that it is super necessary. We cannot avoid this. This is something that we can always do as physicians. And in terms of radiological tests, we have the barbierinema esophagogram that even it seems easy to perform, it's not evident to have the possibility to do that in several scenarios. And also the manometry, we published a study several years ago in which there were slight changes, but in people that had already important or not severe but moderate involvement of the esophagus. So at that point, people has already symptoms. So we need something else to offer to our patients. Again, we have a problem of access. And to finish, I see that I have kind of 2 minutes or something like that to finish. I'm finishing. So we have to remind that this is all the research area. We have started speaking on access, but remind the numbers: less than 10% of people diagnosis, less than 1% of people treated. But imagine that if we know that there are lots of investment, not as much as we want, as we would like, but still lots of investment for make research, not much in Chagas, but still. Imagine that we have tomorrow an ideal treatment, and will it reach patients and on time? So my beloved colleague and team at the time, they do this super relevant study in which we already know, but maybe we didn't have the capability of reflect on patient words and in a real case scenario as they did. So there are multidimensional barriers that prevent people with Tekusa infection and Chagas disease from accessing appropriate care. So these barriers are clinical, structural, systemic, and psychosocial. We have been speaking for almost an hour of the clinical barriers, but maybe we can hear what patients said of their side effects. One patient coming from Mexico told that one went to my head. It was like it erased my mind, and I think I last 1 or 2 weeks taking it. And then they gave me another, and my hands started to swell and got spots and rash and all that. And also took that 1 or 2, 3 weeks, and then I told the doctor I wasn't going to be able to take it anymore. This is the feeling. So imagine this in a patient that has no symptoms. So I'm going to give you something. You are going to feel like this for 2 months, and then I'm not able to tell you if it worked or not in a short time. So this is the real case scenario and a real clinical barrier. Then there are systemic barriers. In terms of patient awareness, not everyone knows what Chagas disease is. Not everyone knows what are the risk factors. Not everyone knows, but the ones that knows maybe knows it as, and we are going to speak on that, as with lots of stigma coming from different areas. So once they know what is Chagas disease and eventually they go to the doctor, and the doctor has never heard about Chagas. What to do in this case? They take no matter what. This is a disease, an infectious disease of poor people from poor countries that are going to kill me. This is the social cultural scenario in some areas. You have to work hardly on that. We have to have the perfect drug, that if we don't work on that, we are not going to reach a good solution. So we have known that they take garlic, the same vinchucas, the triatomines, they ingest the triatomines thinking, triatomines that by the way sometimes contains the parasite, thinking that they are going to cure them, or antiparasitics indicated for other parasitic diseases, and in a format that it is not for human beings. This happens today in Bolivia. The Ivomec is used today in Bolivia for Chagas. So then we have the structural barriers. Not everyone that is living here in Latin America or in any other country have access for different reasons to their doctors. It's expensive. The transportation, the insurance coverage, the financial support that they need, and that was the case of my patients in Barcelona, because you know that in Spain the social security we have coverage, health coverage for everyone. There is an universal health coverage. It's for free for no matter what and for everyone. But they lose their work, and the reason they migrate, it was because their work, not for a disease that has no symptoms, so for their work. So they don't want to lose their work. So these are the structural barriers we have to fight against. And then I have advanced, because this is something is super familiar for us and for the all of us. When I say for us, I say for the all of us, the stigma, because it is not the stigma of the disease because of the characteristic I have mentioned. It is also the stigma for the fact of being migrants. So this is something we have to work in. And the fear of knowing, that was something super interesting that through a responsible research and innovation project that we had several years ago at ISWeb, that I had the lack of coordinate. we have known that the first reason that prevent patients to go to have a test to know if they have T-Cusine infection or not is the fear of knowing, not the fear of the disease. I rather prefer to not to know. If I don't know, I don't have. So I laugh, but it is super serious because this is a super big barrier, but because it is idiosyncratic of the person, it's something difficult to work. And we know because of this study and others that there are many people, that a high percentage of people that exhibit depressive symptoms once they know that they have the infection or the disease. So to finish, what the key question that we have is, or the key things that we should work in is in the better understanding about these host parasite interactions and the biology and what happens inside this interaction, not only to search for new therapeutic targets or strategies, but also for the search of biomarkers of response to treatment and of progression. And we cannot do it alone, but through a strategic alliance. It is super important to be aligned among the research community for them to scale up the message to these people that sometimes take decision, is also aligned with this, that the community research based on the community needs expressed by themselves. We cannot speak by them. We have speak together with them, maybe if they allow us, because we are no one to speak to give our words for them. So but we do, or we try to do. So I think that this is the questions, and this is the way that maybe we can discuss. For sure, you have better ideas that we can work in. So this is the, by the way, our fact sheet in terms of DNDi work. So our goals are to contribute to eliminate Chagas disease as a public health problem. We know that it is kind of difficult to achieve, but this is our goal. And through deliver safer and shorter treatment with all medicines and new ones, and also reduce the mother-to-child transmission. And this not only through research, but also strengthening healthcare systems and addressing health disparities, taking into account these multi-dimensions that Chagas disease has. Thank you very much. I think now, yes, I have finished. I'm happy to take questions.
Yeah. Thank you so much, Maria Jesus. That was a very comprehensive presentation. And as always, it's wonderful to hear you speak. I think, we have a few minutes for questions. And so please feel free to unmute yourself and ask any questions you may have, or of course, you can put them in the chat and I'm happy to ask them for you. To get us started though, I have a question that I have been wanting to ask you. So as you know, as probably everybody on this call knows, PAHO is recommending that clinical entities add Chagas disease screening to prenatal screening. So as that's hopefully happening in many endemic places, has DNDi thought about including pregnant people in clinical trials? This is a big problem with benznidazole, to not use it in pregnancy.
Yes. So in general, DNDi is trying to deal with this topic, inclusion of pregnant women in clinical trials in general, not only in Chagas, but in general terms. You know that because in Chagas is especially relevant. We know that it is not an emergency to treat pregnant women with T-Cusine infection, but we risk to lose them after delivery and focus the follow-up on the babies and not on the mother after breastfeeding. So So we are going to, indeed, it is already started. But we are going to start implementing actions in two sides. Once, try to deal with contraception acceptability in the context of Chagas disease clinical or TICUSA infection therapeutical options, clinical trials in several areas, in several target groups. In indigenous population, pregnant women and women at fertile age, but in the context of indigenous population, in the context of areas that are special social characteristics. So deal with the contraception. In the meanwhile, we don't have a safe medicine to offer to patients. And when we have a safe medicine to be offered to patients, then this general work that it is inside DNDi to include pregnant women in clinical trials, we can try to do that. This is something, again, we are working in. We have not yet one option, one therapeutical option with these characteristics. So we have not a real case. I cannot tell you, yes, we are going to work with this medicine in this clinical trial. I cannot tell you that, but it is a work ongoing on this, because it's a kind of this is a recommendation of WHO to work on this specific topic, on the inclusion of pregnant women in clinical trial. What is the scenario? What is the safest scenario for them? But in the specific case of Chagas, it is we know that we can also be creative in the way we can deal with potential teratogenicities and continue offering women with the possibility of pregnancy these drugs. So,
Yeah.
I don't know if I have answered your question.
Yes, you did. I don't see any questions in the chat. Is there anybody on who has a question who would like to unmute themselves?
It's me, Bob
Hi.
Gelman.
Oh, hi,
Just
Bob.
want to emphasize how effective treatment is for babies, and that at the very least we should concentrate, maybe not diagnosing the moms, but treating the babies. They do very well with benznidazole. We've had, at least in our treatment regimens, we've had very good luck. They appear to eliminate the parasite at that stage. It's an acute infection. And so I would strongly urge people to both diagnose and treat the babies as probably an absolute priority, because everything else we can ask questions and, yes, no. But with this, it seems to be pretty strong that babies who from mothers who transmit, it's worthwhile treating. I'd like to hear what others think as well.
Yeah,
yes, thank you. Yeah, thank you, Dr. Gilman, for the comment. Super important. The efficacy around 100% in babies in this population, and also in children, very high efficacy in between over 90%. And besides, and I take advantage of the comment, treating mothers before becoming pregnant, treating this group of women at fertile age prevents mother-to-child transmission. And there is an addition of evidence in the last 10 years to emphasize that. So I think the mother-to-child binomial before being pregnant and then to take care of the babies is a super efficient measure, not only from an individual health point of view, but also as a public health measure.
And Fred, did you have a question or a comment as well?
Hi. Yeah, I think I could ask a question. Good to see you, MJ. Thank you. Great talk. Uh, we always have this sort of 80% efficacy number. You showed it in your slides. And then, but when I look at the newer data from, Bendita and these types of things, it looks higher than that. Now, I understand that that's just based on PCR and it's only out to 1 year, but I guess I just want to know how you think about that number in terms of success rate with benznidazole in terms of parasitological cure. When I talk to patients, treat a few patients a year, I'm always struggling with what the honest answer to them is in terms of the likelihood of cure. So what do you think is the right number to tell your patients if you're going to treat them with benznidazole in terms of likelihood of cure?
If we are, thank you very much, Fred. I'm happy to see you in the screen.
Yeah.
And this is a super good question. You know that it is a good question because if we speak on parasitological cure and we rely on PCR results, we can speak on this average of 80%, yes. But what does it mean clinically speaking? So we don't have the response. We have to, I think we need a longer follow-up on longer follow-up of cohort studies in order to address this question you put on the table, because we can wonder, we can think there are long-term follow-up of studies like TRAENA or like the observational studies, but these are not randomized studies, so we cannot make the straightforward parallelism between the one and the other one. So now I go to the clinician, the physician, Maria Jesus, the physician. So what I say to my patients, what I used to say to my patients, I used to say to my patients that if there were this 80% of probability of not to see the parasite, and this is linked to the probably with a lack of progression in their organ, probably, not 100%. So it was super important to attend yearly our clinics in order to assess that it was the case. So every year I insist, have you realized it has been 1 year more, you don't have organ involvement, I don't see the parasite, so we are in a good track. But remember, we don't have the 100%. If something happens, we are here. So this is we cannot lie our patients. So this is the reality, and then maybe the confidence relationship that you create with your patient they have also that. So we can open this door to say the reality and to the knowledge that we have. So in real numbers, in the series I used to treat in Barcelona, I can kind of confirm this 80% from a clinical point of view. So there was a match between the clinics, but it is an observation. This is not a trial, so we are based on evidence. So the evidence that we have, with the evidence that we have, this is the response that I think we should give to our patients.
Thank you.
Thanks to you.